Welcome to this virtual class where we are going to talk about topographic anatomy of the thigh. This is the second lecture we are having on topographic anatomy of the thigh. In the first one, we focused on the posterior thigh and popliteal fossa. In this second one, we are focusing on the anteromedial thigh. So just understand that the lecture on the thigh was a bit long, and so I decided to divide it into two for the sake of delivery. We still have more other lectures to handle on topographic anatomy of the lower limb. You can look out for them. Just to bring you to speed about the thigh compartments, we are aware that the thigh is divided into three muscular compartments. These divisions are facilitated by the fascia of the thigh, which we call the fascia lata. This is a deep fascia of the thigh. This deep fascia of the thigh, which we call fascia lata, we are going to talk about it more in this lecture, but just to bring you to speed, it has some extensions which move from it to the femur, which we call intermuscular septa. And this intermuscular septa divide the thigh into three muscular compartments. So we have the posterior compartment, which we call the flexor compartment, and that's the one we've already learned in the previous session. So in this particular session, we're going to learn the other two. We are going to look at the anterior compartment, which we also call the extensor compartment, and the medial compartment, which we also call the adductor compartment. So when we combine these two, we call it the anteromedial thigh, and that's what we're going to focus on. In particular, this is the specific objectives of this particular lecture. We will look at some relevant osteology that are important for this particular lecture concerning the pelvic bone as well as the femur. We'll also look at the skin of the anteromedial thigh and look at the sensory nerves that supply it. After that, we'll also go beyond the nerves and also look at the other superficial structures, in particular, the superficial veins in the thigh and the superficial lymph nodes in the thigh. We'll look at the organization and what is important about them. Beyond that, the superficial structures, we will look at now the fascia lata in great detail, where we're going to focus on its attachments and modifications. After that, we will then state the contents of the anterior and medial muscular compartments of the thigh, especially the muscular components. Then there are some specific spaces that you're going to focus on. Three in particular, we'll look at the femoral triangle, and within the femoral triangle, there's something called the femoral sheath that we look at. And then there's another space called the adductor canal. We look at the boundaries, contents, and clinical importance of each of them. We'll finish with giving a summary of the anatomy of the neurovascular structures in the anterior and medial thigh. We'll focus on the femoral arterial system, the femoral nerve, and the obturator nerve. Let's begin with the first objective, looking at the osteology. So remember that the pelvic bone consists of three bones which articulate at the acetabulum. The ilium itself has the crest and the tubercle there, and it has iliac spines. The anterior spheroiliac spine is this one. The anterior inferior spine is that one. These two are going to be important in this particular lecture. But also remember that there are posterior superior and posterior inferior spines, which we discussed when we're discussing the gluteal region. On the ilium, there's some things to take note of. Still the ischial tuberosity, you know it, and the ischiopubic ramus formed by the ramus of ischium and the inferior pubic ramus. Then on the pubis, we have the superior pubic ramus, which is that one, and the inferior pubic ramus that I've already mentioned. This is the pubic crest, and that's the pubic tubercle, also going to be important. Remember, the superior pubic ramus is the one that goes all the way towards the acetabulum to articulate with the ischium as well as the ilium. And so that's the acetabulum. And this one here is the obturator foramen. Usually the obturator foramen is covered by a membrane, what we call the obturator membrane, but that membrane does not cover it completely. There's a gap at the upper end of that membrane, which we call the obturator canal, allowing passage of some neurovascular structures you're going to see. Also important to note in this particular image is that we have a ligament extending from the anterior spherical spine to the pubic tubercle. We call that ligament the inguinal ligament. That inguinal ligament reflects on itself on the medial end as the lacunar ligament, that's the lacunar ligament, and even more laterally as the pectineal ligament, also called the ligament of Cooper. So those ligaments are also important to note at this point in this particular lecture. As regarding the femur, nothing new so much to say about the anatomy of femur, different from what I said when you look at the posterior thigh. So remember that we have a head, neck, greater trochanter, lesser trochanter, the shaft has the linea aspera. Down here, the femur has those two condyles and the intercondylar notch. Radiologically, that's how the femur would look like on the proximal end as well as the distal end. We can now focus on the sensory innervation of the skin of the anteromedial thigh. So when we use the term anteromedial thigh, we understand that we are focusing both the anterior and the medial side. We can start the skin of the anterior side. The skin of the anterior side of the thigh is supplied by the following nerves. So directly anterior and slightly medial by branches of the femoral nerve. We call them the intermediate cutaneous nerve of the thigh, which is a branch of the femoral nerve, and medial cutaneous nerve of the thigh, which is also a branch of the femoral nerve. So these ones apply at directly anterior and medial aspect. Anterolaterally, we have a nerve that supplies the skin of the anterior thigh. We call that the lateral cutaneous nerve of the thigh. That's an independent nerve. It supplies the lateral aspect of the thigh and of course extending slightly anteriorly. So that will provide a root value of L2 and L3 in that particular region of the thigh. Now those are from directly anterior and lateral as well as medial. Now if you go more medially and especially proximal and medial of a region we call the femoral triangle, there's some nerves that supply the skin of the medial thigh, more proximal and medially. We have the femoral branch of the genitofemoral nerve. We also have the ilioinguinal nerve in that territory. And you have obturator nerve. Those three nerves help to supply the skin of the proximal medial thigh. Femoral branch of genitofemoral nerve, ilioinguinal nerve, and the obturator nerve. And their territories are as well indicated in that particular image there. I'd encourage you to look at a map similar to this in an atlas so that you're able to pinpoint the specific dermatomes of those regions. Like, so dermatome L1 is usually somewhere around here, L2 somewhere there, and L3 is usually anterior knee. Focus on the dermatomes. This particular image doesn't exactly give you the pinpointed dermatome, because giving a range based on the root values of the nerves of that region. I put that intentionally to guide you, but what we want you to know is specific dermatomes of each region. Great, so that's the skin of the anterior and medial thigh, how it is innervated by the cutaneous nerves. Remember, those cutaneous nerves are sensory nerves. After that, we can now talk about the superficial veins as well as the superficial lymph nodes of the thigh. Let me put it this way, that The lower limb is drained by both superficial and deep venous systems. The superficial venous system of the lower limb run just beneath the skin, and they're not accompanied with arteries. The deep venous system accompany arteries. They run between muscles around the arteries. So here, I'll not talk about the deep venous system. I want us to talk about the superficial venous system. The superficial venous system consists of two major veins. We have what we call the great saphenous vein, and we have what we call the small saphenous vein. So basically, we can say it's drained by the saphenous venous system. The great saphenous vein is a larger vein. It runs on the medial aspect of the lower limb. So it starts on the middle side of the foot, goes to the medial side of the ankle, medial side of the leg, posteromedial knee, medial side of the thigh, ascend all the way to terminate proximally into the femoral vein. That's a great saphenous vein. That vein, as it does that, it will be joined by a number of veins, but importantly also that the great saphenous vein is accompanied by superficial lymphatic vessels. And so the territory drained by the great saphenous vein, the lymphatics that accompany that territory will also be taking their lymph to the lymph nodes around this region, which we call the inguinal lymph nodes. We have a superficial group and a deep group of inguinal lymph nodes. On the other hand, the small saphenous vein runs on the lateral side of the foot, and then the posterolateral side of the ankle, goes to the posterolateral side of the leg and even posterior leg, and terminate into the popliteal vein within the popliteal fossa. Similarly, the lymphatics that accompany the small saphenous vein will therefore drain to the lymph nodes within the popliteal fossa, which we call the popliteal lymph nodes. So now that we're talking about the thigh, we'll not expect much of the small saphenous vein to extend into the thigh because it terminates there. But the great saphenous vein is the one that extends much and will be crossing the thigh indeed. Within the thigh, it is joined by a number of superficial veins as well. Some of them are usually named, some of them are not named. But there's a lot of variation in the superficial veins. So importantly, understand that there's one large vein on the middle aspect, great saphenous vein, and is joined by many veins. This vein is running superficial to the deep fascia of the thigh, which we call fascia lata. At the point of termination into the femoral vein, there's an opening within the fascia lata, which we call the saphenous opening, to allow the passage of the great saphenous vein into the femoral vein. At that point where the great saphenous vein terminates into the femoral vein, there are a number of veins which are named, which also join it just before it empties its blood into the femoral vein. So those veins join the great saphenous vein around the saphenous opening just before it empties into the femoral vein. It is important to know the names of these superficial veins. The one that comes from the external genitalia is called the superficial external pudendal vein. It drains the external genitalia. One that drains the lower part of the anterior abdominal wall is called the superficial epigastric vein. And one that drains again still the anterior abdominal wall, but more laterally, as well as some parts of the gluteal region, the superficial circumflex iliac vein. So those three veins join the great saphenous vein at the saphenous opening just before it enters into the femoral vein, which is the deep vein. So basically, those are the veins, superficial veins of the lower limb. Remember, saphenous venous system. The last image there shows you, similar to what the second image is showing you, the veins together with the various superficial nerves or cutaneous nerves of the thigh. We can now talk about the superficial inguinal lymph nodes. So superficial inguinal lymph nodes are the lymph nodes, part of the lymph node that drain the lower limb. The superficial inguinal lymph nodes are arranged in two groups. We have a horizontal group and a vertical group. The horizontal group of superficial inguinal lymph nodes are arranged just below the inguinal ligaments. The vertical group of the superficial inguinal lymph nodes are arranged along the termination of the great saphenous vein. So remember, there's a vertical group and a horizontal group. This horizontal group has two components. There's a lateral component and a medial component as well. The medial component of the horizontal group receive lymphatics which come from the external genitalia, as you can see in this image. They also receive lymphatics which come from the anterior abdominal wall, slightly medially. The lateral group of horizontal group of lymph nodes receive lymphatics which come largely from, again, anterior abdominal wall laterally, extending even from the gluteal region and some proximal parts of the thigh. Then the vertical group of superficial inguinal lymph nodes are the ones which are actually following the territory of the great saphenous vein. And so all the lymphatic vessels that accompany the great saphenous vein are most likely going to drain their lymphatics into the vertical group of superficial inguinal lymph nodes. Having said that, it therefore means that this vertical group of superficial inguinal lymph nodes drain a big part of the superficial structures of the lower limb. All we can say that the whole of the free lower limb, where the free lower limb here refers to the foot, the leg, and the thigh, the whole of that, most of that will drain into the vertical group of superficial inguinal lymph nodes, except the territory which is drained by the popliteal lymph nodes. Now remember, the popliteal lymph nodes are drained, or rather drain the lymphatics which accompany the small saphenous vein. And if you remember, the small saphenous vein is on the lateral side of the foot, the heel, the posterior and the lateral calf, and terminate into the popliteal fossa. So that's the territory of the small saphenous vein. The lymphatics that accompany it will also go to the popliteal lymph nodes. So occasionally you may see some swellings in the inguinal region due to lymph nodes. It just tells you that there could be some infection somewhere along the territory drained by the great saphenous vein. Therefore, also the accompanying lymphatics will carry that information. Great. Having said so, we are now dealt with the superficial structures. Let's go slightly deep and talk about the deep fascia of the thigh. The deep fascia of the thigh is called the fascia lata. The fascia lata embraces the muscles of the thigh really and separate them from the subcutaneous tissues that we've talked about. This fascia lata is attached proximally to a number of things. We can say it's attached to the iliac crest, as you can see in this image. It is also attached to the anterior superior spine. Then going more anteriorly, it's attached to the inguinal ligament there. It will attach also to the pubic bone, so the pubic tubercle there, along the pubic symphysis there, then extend posteriorly to be attached to the sacrum. It was attached to the sacrotuberous ligament. It's attached to the isthiopubic ramus as well. So that's an extensive proximal attachment. Distally, the fascia lata is attached to the bones of the leg. That means tibia and fibula. It's also attached to the patella, but it also merges with the fascia of the leg, which we call the fascia cruris. So very extensive insertion or distal attachment as well. The fascia lata has some modifications which I wish to share with you. One is something called the iliotibial band, or some books call it the iliotibial tract. The iliotibial band is the lateral thickening of the fascia lata. So what I'm saying here is that the fascia lata is thickened on the lateral aspect of the thigh, and that thickening is called the iliotibial band. This thickening forms the insertion of two important muscles in the lower limb. Posteriorly, it forms the insertion of the upper three-quarter fibers of the gluteus maximus muscle. We had mentioned that when we discussed the gluteal region. Anteriorly, it forms the insertion of a muscle called the tensor fascia lata. So two muscles insert into the iliotibial band, one from behind, one from the front. Iliotibial band extends all the way and attaches onto a groove within the tibia on the lateral condyle of tibia. So that's the iliotibial band. Another modification of the fascia lata is an opening above here for the entry of the great saphenous vein. We call that opening the saphenous opening. So the saphenous opening is a large opening for the passage of the great saphenous vein. However, the great saphenous vein is not the only structure that will go through the saphenous opening. Other than the great saphenous vein, we had mentioned some three superficial veins that terminate into the great saphenous vein just before it empties into the femoral vein. So those three veins will also go through the saphenous opening: superficial circumflex iliac, superficial epigastric, and superficial external pudendal veins. Apart from that, the efferent lymphatic vessels, which come from the superficial inguinal lymph nodes, pass through this region to enter the deep inguinal lymph nodes, which are now deep to the fascia lata. So there are efferent lymphatics from the superficial inguinal lymph nodes, but there are definitely afferent lymphatics to the deep inguinal lymph nodes. They pass through this opening as well. Having said so, the fascia, the superficial fascia that will be covering that space over the saphenous opening will appear to be penetrated by a number of structures. That superficial fascia that covers the saphenous opening is sometimes called the cribriform fascia. It's actually called the cribriform fascia. Now, I put it with asterisk to remind me that in strict sense, the cribriform fascia may not be a modification of the fascia lata. It is just extension of superficial fascia over the saphenous opening. But it is worth mentioning because it covers the saphenous opening. And so it's acting as a deep fascia at that particular point, because beyond that, we have the deep structures. This fascia is penetrated by a number of things, and that is why it will give it a sieve-like appearance. And that's why it's called the cribriform fascia. Last but not least, the fascia lata has intermuscular septae. We've already mentioned this. The intermuscular septa divide the thigh into various muscular compartments. These septa attach from the fascia lata to the linea aspera of the femur. So that brings me therefore to the next agenda there, to talk about the compartments of the thigh, specifically the anterior and the medial compartments of the thigh. Just mention the muscular contents of those compartments. Just to remind you that the deep fascia of the thigh is fascia lata, and that is it. This is the fascia lata. And that this fascia lata has intermuscular septa like this one, or that one, which extend from it to the femur, linea aspera in particular, hence dividing the thigh into muscle compartments. We have three muscle compartments. The posterior compartment, also called flexor compartment, is on the posterior thigh. We've already discussed that one in the previous class. Anterior compartment, also called the extensor compartment, is this one, the muscles in front of the femur or in front of the thigh. And then we have the medial compartment, which we also call the adductor compartment on the medial aspect of the thigh. So in this particular lecture, we are focusing on the anteromedial thigh, anterior and medial thigh compartments. Let's start with the anterior muscular compartment of the thigh. The muscles in the anterior compartment of the thigh basically are the ones that we are calling the extensor compartment. There's a reason why they're called so. We call it the extensor compartment because they cause extension at the knee joint. Now, it is important to note that there are many muscles in the anterior thigh compartment. Not all of them will cause extension at the knee joint though, but there's some large muscles which actually cause extension at the knee. And perhaps these are the only muscles that will cause extension at the knee joint. And that is why this group is therefore given that name, the extensor compartment. They're the only ones that extend. In particular, there's a large group of muscles within this category that we call the quadriceps femoris. From muscle entomology, you remember that when we say a muscle, it's called quadriceps, it means that it has 4 heads of origin. So there's a unit here with 4 heads that is particularly important in extension of the thigh, extension of the leg at the knee joint. Now, these are the 4 muscles which constitute the quadriceps femoris unit. This one here is called vastus medialis. Vastus means wide, and so it's a wide medial muscle. We have vastus lateralis here. We have this one, which we are calling rectus femoris. Deep to the rectus femoris is another muscle that we call vastus intermedius. So 4 muscles: vastus medialis, vastus intermedius, vastus lateralis, and rectus femoris. Those 4 constitute the quadriceps femoris unit. These are the muscles that usually cause extension at the knee joint. And that is why we are calling this compartment the extensor compartment. However, there are also other muscles which are within this particular compartment. This long one is called sartorius muscle. It's the longest muscle in the body, traversing both the hip joint as well as the knee joint, and therefore acting in both of them. This other one is called the tensor fasciae lata, the one I mentioned to you earlier. It inserts into the iliotibial band, as you can see there. Then there's this one here. We call this the iliopsoas unit, consisting of a muscle called iliacus on the lateral aspect and another one called psoas major on the middle aspect, except that they merge together. And so we call this the iliopsoas unit. Then lastly, we have this one, which we call pectineus muscle, found both in the anterior compartment as well as in the medial compartment of the thigh. Now let's talk about the actions of these muscles in the anterior thigh. The quadriceps femoris unit is principally responsible for extension of the leg at the knee joint. Usually, for extension to occur, the force from the quadriceps femoris unit will converge through this structure, which we call the quadriceps tendon. And then here, the patella. Then from the patella, we'll have the patellar ligament. And then we'll have a projection on the tibia, which we call tibiotuberosity. So the quadriceps femoris unit, quadriceps tendon, the patellar ligament, and lastly, the tibial tuberosity. Those 5 constitute the extensor mechanism or the extensor apparatus of the knee. In addition to extension at the knee, The rectus femoris muscle, this one, also causes flexion at the hip. The other three components of the quadriceps femoris do not act on the hip because they do not cross the hip joint. They arise from the femur. Rectus femoris is the only member of the quadriceps femoris unit that acts on the hip joint because it arises from the anterior inferior iliac spine with a straight head and a reflected head arising from the groove above the acetabulum. So this muscle will flex the hip as well as extend the knee. The other three components of the quadriceps femoris unit will only extend the knee. Apart from rectus femoris, tensor fascia lata also flexes the hip. Sartorius also flexes the hip joint. Iliacus will also flex the hip joint. Psoas major will also flex the hip joint. Indeed, the iliopsoas unit is the main hip flex actually. Pectineus also flexes the hip joint. So you see that there is a lot of flexion at the hip caused by the muscle of the anterior thigh as well. Take note that there are some muscles with more than one action from that list, like rectus femoris that I've mentioned to you. Also, tensor fascia lata, apart from flexing the hip joint, tensor fascia lata can also abduct the hip joint. Sartorius has multiple actions, maybe 3 actions on the hip joint and 2 actions at the knee joint. At the knee joint, Sartorius causes flexion. Now remember, it's in the anterior compartment, it causes flexion. So when we say that anterior compartment is an extensor compartment, doesn't mean all the muscles extend. Sartorius actually flexes the knee joint because it passes behind the joint. So it causes flexion at the knee as well as medial rotation at the knee joint. The knee joint that is flexed can medially rotate slightly, caused by Sartorius. At the hip joint, Sartorius causes 3 actions. It will flex the hip, it causes abduction at the hip, and it also causes lateral rotation at the hip. So multiple actions for Sartorius. Pectineus is another one with multiple actions. Apart from flexing the hip joint, pectineus is also an adductor muscle. So it can adduct the hip joint as well. Great, so some muscles have more than one action. Take note of that and grasp it well. Let's talk about the innervation of the muscles of the anterior compartment. Most of the muscles that we've mentioned in the anterior compartment are supplied by branches of the femoral nerve, most of them. There are a few exceptions though. Psoas major receives its innervation from up because it arises from the lumbar vertebra. So it will receive its innervation directly from some ventral rami coming from lumbar nerves. Tensor fascia lata receives its innervation from the superior gluteal nerve. Remember, superior gluteal nerve innervates gluteus medius and minimus in the gluteal region, then tensor fascia lata. We can say that superior gluteal nerve is actually the nerve of abduction because those 3 muscles cause abduction at the hip joint. How about the nerves? So the arterial supply, the blood vessels which are in the anterior thigh. The blood vessels that supply the mass of the anterior thigh can either be direct or indirect branches of the femoral arterial system. We'll talk more about the femoral arterial system in this particular lecture, so let me not preempt much about the femoral arterial system at this point. Now we can talk about the medial muscular compartment of the thigh. The muscles on the medial aspect of the thigh principally cause adduction at the hip joint and so we call it the adductor compartment. We have some 5 key muscles in this particular group. We have the pectineus muscle that we've already mentioned as being part also of the of the anterior compartment. Now it's also part of the medial compartment as well. We have adductor brevis, adductor longus, and adductor magnus, which is down here. It's a huge muscle. And then we have gracilis. So those 5 are the muscles which belong to the medial compartment. This image helps us to capture each of them again. Pectineus there, adductor brevis, gracilis. We have adductor longus and adductor magnus. Remember, adductor magnus has an opening separating its tendinous from its aponeurotic part. That opening is called the adductor hiatus. What are the actions of these muscles? They cause adduction at the hip. But in addition to that, there's some muscles which have other actions. For example, gracilis, apart from causing adduction, also flexes the knee joint. Maybe at this point, I need to mention something. We have sartorius, gracilis, and semitendinosus. Those 3 muscles are very long, slender, and insert in a common aponeurosis. The common aponeurosis for those 3 is called the pes anserina. It means the duck's foot. There's an aponeurosis that looks like the duck foot for common insertion of gracilis, semitendinosus, and the sartorius muscle. They all flex the knee joint, as you've seen. Pectineus muscle causes adduction as well as flexion at the hip. Adductor magnus, we underscored that it has 2 parts. The aponeurotic part is the adductor part, causes adduction, but the tendinous part is the hamstring part that could also participate in extension at the hip joint. The nerve supply to the muscles of the medial compartment is principally by the obturator nerve. So the obturator nerve is a nerve supply of the of the medial compartment of the thigh. However, it is important for you to note that even though obturator nerve is a nerve of the medial muscular compartment of the thigh, this is the obturator nerve, there are some muscles in the medial aspect of the thigh that have dual innervation. Let's mention them. Adductor magnus receives obturator nerve as well as tibial nerve. Remember, it's part of it belong to the hamstring compartment. Pectineus muscle receives both femoral nerve as well as obturator nerve. Remember, it is classified in the anterior as well as medial compartment. The adductor brevis dual innervation is a contentious one. Maybe from a philosophical point of view, we can say it still has dual innervation. In this understanding, obturator nerve usually has 2 divisions. The anterior division, which runs anterior to adductor brevis, and posterior division, which runs posterior to the adductor brevis. Both divisions of the obturator nerve supply the adductor brevis muscle. So with that, we can give it a benefit of doubt that it also has a dual innervation. But remember, they're all from obturator, either way. The other muscle that you've learned so far that has dual innervation should be in your head is the biceps femoris muscle, the long head receiving tibial nerve and the short head receiving common peroneal nerve. Great, now let's look at the anatomical spaces in the lower limb. Sorry, in the thigh, and specifically the anteromedial thigh. We'll focus on the femoral triangle, femoral sheath, and adductor canal. We might spend some time here, but Just follow slowly so that you grasp it right. The femoral triangle, as the name suggests, is a triangular space. It is located in the proximal part of the anteromedial thigh. It's an inverted triangle, so the base of the triangle is superior. The apex of the triangle points inferiorly. This image captures for you the location of the femoral triangle, with this being the abdomen. So this is the thigh, this is lateral, this is medial. What are the boundaries of this triangle? Superiorly, which therefore qualifies to be the base, is the inguinal ligament. The medial boundary of this triangle is the medial border, the medial margin of the adductor longus muscle. The lateral boundary of this triangle is again medial border of the sartorius muscle. There's usually a tendency to say that now if you're talking about the lateral boundary, then you should say lateral border, which is not true. It's the medial border. Again, a common mistake some people make is to think that then the medial border of the triangle is formed by the lateral margin of adductor longus. It is not true. It is both medial border of adductor longus, medial border of sartorius muscle. So this is sartorius muscle, this is its medial border, this is adductor longus, this is medial border. The apex of the triangle points down, and usually the apex of the triangle continues into another space below the sartorius muscle. We call that space the adductor canal. We'll talk about it. So at this point, we can just say that the apex of the femoral triangle is the beginning of the adductor canal. This is the apex. So you see this is sartorius, and that is the adductor longus there, and this is gracilis. So this is the apex of the triangle at that point, which is replicated here. So this is the apex of the triangle somewhere there. The beginning of the adductor canal is the termination, is the apex of the femoral triangle. Now let's talk about the floor of the femoral triangle. The floor of the femoral triangle is formed by some muscles. Let me change that pointer so that you're able to see as I point them. The floor of the femoral triangle is formed by some muscles. We prefer naming them in order. So if this was the middle boundary of the triangle, this means it's the floor. So which structures form the floor of the triangle from medial to lateral? We have adductor longus muscle up to there. Then you have pectineus muscle up to there. Then we have the iliopsoas unit. The iliopsoas unit being a combined unit being formed by psoas major medially and the muscle iliacus laterally. So those 3 or 4 muscles form the floor of the femoral triangle from medial to lateral. The roof of the femoral triangle is formed by fascia lata that covers the femoral triangle. So we have the fascia lata covering the femoral triangle. But remember, fascia lata has an opening, which we call the saphenous opening. And that saphenous opening is covered by the cribriform fascia. So the saphenous opening covered by cribriform fascia is part of the roof there. If you talk about the structure, therefore it would be the cribriform fascia, and the other region is the fascia lata. Remember, there's some structures which are in the subcutaneous tissue of that region. In particular, we have the superficial inguinal lymph nodes, which are found on the roof of the femoral triangle. Also remember that there's some structures which go through the cribriform fascia. They'll be partly in the roof of the femoral triangle as well. Great, so let's go deeper into the triangle and we talk about the contents of the femoral triangle. So which structures are found within the triangle? The femoral triangle contains the following structures. So we do have the femoral nerve and its branches. This is the femoral nerve and the branches it gives. Most of those branches are given to the muscles of the anterior thigh. A number of them are not named. A few of them are named. Among the ones which are named is this one, nerve to vastus medialis. It's a branch from the femoral nerve to go to the muscular anterior thigh. Apart from the muscular branches, there are several cutaneous branches, especially the ones we mentioned, the anterior, intermediate cutaneous nerve of the thigh and the middle cutaneous nerve of the thigh. They are still a branch of the femoral nerve. As well as there's another cutaneous nerve which is going all the way deep down there. That is the saphenous nerve, which is a branch of the femoral nerve. Apart from cutaneous and muscular branches, there could also be articular branches, but we don't have to mention them. Understand that femoral nerve is a content of the femoral triangle. We have the femoral arterial system also, and their branches. When you talk about femoral arterial system, you're referring to the common femoral artery, the deep femoral artery, which is shown here, and the superficial femoral artery, which is cut here. Remember, the common femoral artery divides into superficial femoral, which continues all the way, passing through the thigh largely, and then the deep femoral artery, which gives you seven branches within the thigh. So they have several branches as well. They are contents of the femoral triangle. We have the femoral vein and its tributaries. The tributaries of the femoral vein will accompany the branch of the femoral arterial system. They're also contents of the triangle, but remember also the great saphenous vein is a termination, or rather terminates into the femoral vein. The great saphenous vein is therefore also partly the termination of it is a content of the femoral triangle. We have deep inguinal lymph nodes. These are the lymph nodes which receive from the superficial inguinal lymph nodes that we've already mentioned. The deep inguinal lymph nodes will follow arteries. Generally, the arrangement is that superficial lymphatics accompany superficial veins. Deep lymphatics accompany the deep arteries, or the arteries basically. Apart from those things, the femoral branch of the genitofemoral nerve is also a content of the femoral triangle. Remember, it is contributing to the supply of the skin over the femoral triangle. So how is femoral triangle clinically important? Why are we learning about it? Commonly, we see some swellings in the femoral triangle. When you see swellings in the femoral triangle, it could be because of a number of things. Maybe some lymph nodes are swollen, superficial inguinal lymph node, that's a common phenomenon. Could be femoral hernia. We'll talk more about femoral hernia in the next few slides. We can use the femoral triangle to get pulsations of the femoral artery. For whatever reason, you want to get the pulsations, you want to count, fine, or you want to get the pulsation of the artery because you want to put some instrumentation through the artery. We call those ones interventional procedures which are being done in the cardiovascular system. So you're putting some instruments through the femoral artery, or maybe you're doing that because you want to estimate where the femoral vein is because perhaps you want to withdraw some blood. So all those can apply. Now, related to the femoral triangle is a structure we call the femoral sheath. The femoral sheath is a common sheath that contain the femoral vessels, especially the common femoral vasculature, femoral artery, common femoral vein. They are contained within a common sheath, as we can see there, within the femoral triangle. This sheath is formed by continuation of the fascia within the abdomen that extend into the thigh. So there are two fascia in the abdomen that extend into the thigh to constitute the femoral sheath. Posteriorly, there's a fascia that covers the muscle iliacus. So we call that fascia the iliac fascia, or the fascia iliacus. It is on the posterior aspect of the abdominal wall, and so it contributes to the formation of the femoral sheath posteriorly. Then there's another fascia, which is in the anterior abdominal wall, therefore contributing to the formation of the femoral sheath anteriorly. We call it the fascia transversalis. So fascia transversalis anteriorly and fascia iliacus posteriorly contribute to formation of the femoral sheath. This image shows you the femoral sheath again with the femoral vessels within the sheath. The femoral sheath has some compartments. There's some septa, two septa that go through like this, so dividing the femoral sheath into three compartments. We have the lateral compartment of the femoral sheath. The lateral compartment of the femoral sheath is where the common femoral artery runs. So it contains the femoral artery, but that compartment also contains the femoral branch of the genitofemoral nerve. Then you have the intermediate compartment. So this image shows you the lateral compartment with the two structures there, femoral artery and femoral branch of genitofemoral nerve. The intermediate compartment, this one, contains the femoral vein. Then we have this medial compartment of the femoral sheath. The medial compartment of the femoral sheath contains some loose connective tissue, and so it's just a potential space. This potential space is the one we call the femoral canal. Remember, it's a potential space, just contains loose connective tissue. Well, apart from loose connective tissue, we may also have some lymph nodes within the femoral canal. The lymph nodes found within the femoral canal is specifically part of the deep inguinal lymph nodes, also known as the lymph node of Cloquet. So that is the femoral canal, the potential space on the middle aspect of the femoral sheath. Let's say something more about that in this particular section. So you see, this is a cross-section through the femoral sheath, lateral compartment, femoral artery, and femoral branch of genitofemoral nerve. The middle compartment, femoral vein, the middle is the intermediate compartment. Then the medial compartment has loose connective tissue, but basically containing lymphatics with the node of Cloquet. The node of Cloquet is one of the deep inguinal lymph nodes which drain the glans penis and the glans clitoris. So it drains the glans penis and the glans clitoris. This image captures for you, again, the region of the sheath, and just you noting that the region of the canal is a potential space, has some loose connective tissue. So let's talk about the femoral canal in great detail. We've said it's a potential space in the medial compartment of the femoral sheath. And you can see that this space has some boundaries, and you can now figure out the boundaries. Posteriorly, you'll expect pectineus muscle and perhaps the fascia covering it. Medially, you'll expect the septa separating the medial and the intermediate compartment. Remember that septa separated from the femoral vein. Posteriorly, apart from the pectineus, we'll also expect the smooth surface of the superior pubic ramus, which we call the pecten pubis, also being there. Anteriorly, we'll expect the inguinal ligament to be an anterior boundary. And medially, we have the lacunar ligament there. Related to the boundaries of the femoral canal is what we call the femoral ring. So what is the femoral ring? The femoral ring is the proximal mouth of the femoral canal. Understand that if you have a tubular structure, so that tubular structure is the canal, but that tubular structure might have two openings, the proximal and the distal opening. So the proximal opening, that opening that empties into the abdominal cavity, is what we call the femoral ring. It is the abdominal mouth of the femoral canal. Therefore, if the whole of this is the canal, this particular one part is the ring. The femoral ring has some specific boundaries. Some of them are almost similar to what we've mentioned, but maybe just attention is taken on the posterior aspect. We don't now talk about the pectineus muscle, the fascia covering it, but in particular, we talk about the pectineal ligament. The pectineal ligament is the ligament of Cooper that is in the posterior aspect of the ring. In this image, we see that as well. So the ring specifically will have the pectineal ligament posteriorly, medially the lacunar ligament, anteriorly the inguinal ligament, and medially the septum separating the ring from the femoral vein. So what's the clinical importance of the femoral canal? The femoral canal is important clinically because the site of occurrence of inguinal herniations, not inguinal herniations, sorry, femoral herniations. So the femoral ring is the mouth through which structures from the abdomen will herniate. Now, maybe you need to understand what's hernia. A hernia is a protrusion of an organ through a defect. Most of the time, this will be protrusions of abdominal organs through some defects. In this case, abdominal organs protrude through the femoral ring. That means that they threaten to go to the thigh. That's herniation. There are different types of herniations in this region. The commonest herniation is usually the inguinal herniation, though, but that's not the one we're discussing right now. Right now, we're discussing femoral herniation. Femoral hernias are hernias which occur through the femoral ring to go towards the thigh. These femoral hernias are known to be more common in females, and there's some anatomical reasons for this. One, we expect females to have wider pelvis compared to males, and so the potential space is greater in the female. Therefore, they're more prone to femoral herniations. Second reason is a philosophical one, but true. If you are to assume that the femoral sheath is constant in both male and female, then introduce blood vessels into both. So femoral vessels are being introduced in both sheaths, in the male and female. We know as a fact that the blood vessels are usually smaller in female than in males. So if you introduce smaller blood vessels in a constant sheath, then the potential space is going to be larger. And that is what happens in female. Therefore, also explaining why femoral herniations are more common in females than males. Don't confuse this with the inguinal herniations, which are more common in males than females. And when we discuss inguinal herniations, you'll know why they are more common in males than females. Great. The next space I want us to discuss is the adductor canal. So in terms of its location, the adductor canal is an intermuscular tunnel located below the sartorius muscle. Because it is found below the sartorius muscle, we also call it the subsartorial canal or the Hunter's canal. What are the extents of the canal? The canal extends from the apex of the femoral triangle, which will be somewhere up there. It will extend all the way to what we call the adductor hiatus. The adductor hiatus being the opening within the adductor magnus muscle. So we have the apex of the femoral triangle up here. That is the beginning of the tunnel. And down we will have the adductor hiatus. This is the adductor hiatus, is an opening through the adductor magnus muscle. Now let's talk about the boundaries of the adductor canal. For us to understand the boundaries well, we'll have to use a cross-sectional image to give us a better view. But before that, understand that it's just below sartorius muscle. So usually that sartorius muscle will be forming the roof of the canal, but in cross-section, we'll notice that that roof is actually either the medial wall or the anteromedial wall. Maybe this is better. These are cross-section through the thigh. The muscle labeled B is sartorius muscle. Let's orient it first. Maybe this is the anterior aspect. This is the posterior part. This is the medial side. This is the lateral side of the thigh. So the muscle sartorius, labeled B, is the roof, but we can also say it is the medial wall or the anteromedial wall. Then we have the lateral wall, which we can also say is the anterolateral wall, formed by this muscle labeled A. This is vastus medialis muscle. Don't confuse this lateral and then say vastus lateralis, which is this one. Vastus lateralis is very far away from that particular tunnel. It is the vastus medialis muscle. This is vastus lateralis, this is vastus medialis, this is vastus intermedius, and this is rectus femoris muscle. The posterior wall, which is here, can be viewed as the floor. So the posterior wall of this particular tunnel is formed by two muscles. It will depend on which level we are in. So on the upper parts, the floor is formed by the adductor longus muscle, which is this one. And on the lower parts, is formed by the adductor magnus muscle. Understand that once the adductor longus has already inserted, the tunnel still extends. And so beyond that, we have the adductor magnus muscle. So this section is a more superior section. That is why we see adductor longus and adductor magnus not very close. But once this one has terminated, it's the adductor longus that will form the posterior wall of the tunnel. And indeed, it is the adductor magnus that has an opening where these vessels will go through to join the popliteal fossa. So this image captures for us that concept of adductor longus ending somewhere there, then adductor magnus is the one that's proceeding all the way. Forgot to tell you, but not too late, that usually just beneath sartorius, the sartorius itself is it's not in contact with the contents of the tunnel really, because there's some fascia beneath sartorius. And even that fascia usually contains some plexus of nerves, subsartorial nerve plexus. You can check on the subsartorial nerve plexus and the nerves that make up the plexus. They usually some 3 nerves. Now, what are the contents of the adductor canal? We have blood vessels. The vascular contents of the adductor canal are the superficial femoral vessels. We have superficial femoral artery and the superficial femoral vein. Then you have some nerves. The nerves which are found here are the saphenous nerve. This is the terminal branch of the femoral nerve. It's a cutaneous nerve. We have nerve to vastus medialis, and you have some small branch from the obturator nerve. So this is a nerve to vastus medialis. It's partly within the tunnel. This is the saphenous nerve. It goes through the tunnel and come out. You can see the superficial femoral vessels there. The twig from the obturator is not illustrating this image. Great. So that brings me, therefore, to the descriptive anatomy of the neurovascular structures of the anteromedial thigh. We'll focus on 3 major things: the femoral arterial system, the femoral nerve, and the obturator nerve. Let's start with the femoral arterial system. We might spend some time on this slide, but let's just follow through slowly. So you know that from the heart, we have a large artery, which we call the aorta. The aorta divides into 2 when it reaches the lower part of the abdomen, the right and the left common iliac arteries. So each of those will go to different sides of the body. Each common iliac artery divides into two again. We have what we call the internal iliac artery and the external iliac artery. The internal iliac artery give you arteries which supply the structures which are inside the pelvic cavity. So it will supply the rectum, the urinary bladder, the uterus, and the like. However, there are some branches of the internal iliac artery that extend to even go to the gluteal region. The superior gluteal artery and the inferior gluteal artery are those arteries. They are branches from the internal iliac system, but they go to the gluteal region. So they still contribute to blood supply of the lower limb. The internal iliac still contribute, but largely on the gluteal region side. Well, it also gives us another artery, which we call the obturator artery, that usually run together with the obturator nerve through the obturator canal to go to the medial aspect of the thigh. It doesn't supply much of the thigh though, but some small contribution it does, yes. Now that is internal iliac. The external iliac artery is called so because it leaves the ilium. This is the main artery of the lower limb. The artery changes name from external iliac to common femoral artery when it passes the inguinal ligament. So beyond the inguinal ligament, we talk about the common femoral artery. The common femoral artery is therefore one of the components of the femoral arterial system. The common femoral artery will divide in the thigh into two major branches, the superficial femoral and the deep femoral, as Ed mentioned earlier. Maybe the second image helps us capture that well. We have the common femoral artery, which divides into superficial femoral and the deep femoral arteries. The deep femoral artery is the main artery of the thigh. So it supplies the structures in the thigh. The superficial femoral artery doesn't supply a lot of things in the thigh. Perhaps one of its named branches is this one here, called the descending genicular artery, that it gives just before the artery disappears through the adductor hiatus to enter the popliteal fossa. But it doesn't give us so many branches in the thigh. So the main artery of the mass of the thigh is the profunda femoris artery, which is also called the deep femoral artery. Femoral arterial system therefore consists of common femoral artery, the deep femoral artery, superficial femoral artery. The superficial femoral artery continues to the back of the knee as the popliteal artery. Now let's bring some meat into that skeleton that I've given you. Let's start here from the external iliac artery. Just before the external iliac artery passes below the inguinal ligament, it gives some branches. Some of those branches named are the inferior epigastric artery, which goes to the anterior abdominal wall, and the deep circumflex iliac artery, as the name suggests, goes towards the ilium, and so supplying the structures in that region. After the artery traverses the inguinal ligament, just below it, doesn't go through it, but below it, it becomes a common femoral artery. Common femoral artery usually gives some branches, superficial branches. There are 4 superficial branches given by the common femoral artery before it gives us the deep and the superficial femoral. These 4 superficial branches are these ones. We have superficial epigastric artery, which goes to the anterior abdominal wall. Superficial externopudendal, as well as the deep externopudendal, which go to the external genitalia, and superficial circumflex iliac, which also goes towards the anterior superior iliac spine, and perhaps can even extend to reach some muscle in the gluteal region as well. So those are superficial branches of the common iliac artery before its terminates, of the common femoral artery before its termination. There are branches of the common femoral artery before the common femoral artery bifurcates into superficial and deep femoral artery. After it has bifurcated, I've mentioned to you that the superficial femoral artery does not give you many things in the thigh. So it will just go through the thigh into the adductor canal. It will then go through the adductor hiatus to become the popliteal artery. And we'd already talked about the branches of the popliteal artery in the previous lecture. So I'll not venture into that in this particular session. But there are many, if you remember. Let's talk about the profunda femoris artery, also called the deep femoral artery. The profunda femoris artery gives you many branches which supply the thigh. Some of those branches are named, and I want to talk about the ones which are named. In particular, it gives you some arteries which go around the proximal femur, and so we call them circumflex femoral arteries. One given on the lateral aspect is called the lateral circumflex femoral artery, or lateral femoral circumflex. Then there's one that goes in the middle aspect, which we call the medial circumflex femoral artery. So medial circumflex femoral artery and lateral circumflex femoral arteries are branches of the deep femoral artery. They go around the femur. Even though they are branches of the deep femoral artery, there are some common variations about them. Either one or both of them can come from either the deep femoral artery or the common femoral artery. Either one or both can come from either deep femoral or common femoral artery. Remember, I didn't mention superficial femoral artery. Now, the circumflex femoral arteries have some named branches as well. The lateral circumflex femoral artery has many branches, but 3 are named. We have one going up, the ascending branch of the lateral circumflex femoral artery. That one goes to the trochanteric anastomosis, if you remember that story in the gluteal region. The transverse branch of the lateral circumflex femoral artery goes to the cruciate anastomosis, found almost around the level of the lesser trochanter. The descending branch of the lateral circumflex femoral artery goes all the way to the genicular anastomosis. That's the anastomosis around the knee joint. We'll talk about this anastomosis when we discuss the knee joint anatomy. Medial circumflex femoral artery has 2 major branches. The ascending to the trochanteric anastomosis at the level of the trochanteric fossa, and transverse branch to the cruciate anastomosis at the level of the lesser trochanter. We rarely talk about a descending branch of the medial circumflex femur. So those are the branches of the profunda femoris. After giving the circumflex branches, the profunda femoris continues deep to adductor longus, but anterior to adductor magnus. And then it gives branches which go through the adductor magnus to supply the structures in the posterior muscular compartment. Those branches given by the profunda femoris artery are the ones we called earlier the perforating arteries. So first, second, and third and fourth perforating arteries are branches of the profunda femoris. The fourth perforating artery is usually considered the terminal branch of the profunda femoris artery. The perforating arteries go beyond the medial compartment, anteromedial compartment, to supply the posterior compartment of the thigh. They're the ones that contribute to the blood supply of the posterior compartment. So related to this are some anastomosis. Remember, the perforating arteries form the longitudinal anastomosis in the back of the thigh. Cruciate anastomosis is located at the level of the lesser trochanter, formed by anastomotic branch of the inferior gluteal, anastomotic branch of the first perforating artery, and the transverse branches of the medial and lateral circumflex arteries. Trochanteric anastomosis is formed by ascending branches of medial and lateral circumflex femoral artery together with anastomotic branches of superior and inferior gluteal arteries, located at the level of the trochanteric fossa. Longitudinal anastomosis is found at the level of the posterior thigh, and those are the components of the longitudinal anastomosis. It's through this anastomosis that you may sometimes have blood going to the lower limb if you were to block the main arterial tree at this particular point. Blood to the lower limb can still reach through the longitudinal anastomosis, although if it's acute, then maybe that will not suffice. But if it's long-term progressive, the anastomosis will open up slowly. What I want to note is that the longitudinal anastomosis also has connection with a branch from the popliteal artery. And so through that, blood can still reach the lower limb, the leg, if you are to block the main arterial system at this region. We will talk about genicular anastomosis when we discuss the knee joint, but there are several branches we've mentioned so far that contribute to the anastomosis around the knee joint. Now let's talk about the nerves in the thigh. Two nerves we're going to talk about, the femoral nerve and the obturator nerve. We start with the femoral nerve. Now let me explain what that means. First here, this is the lumbar plexus from the lumbar nerves, and from this lumbar plexus, we can see the femoral nerve there being formed from L2, L3, L4 nerve segments. Let's talk about how a spinal nerve is formed so that we understand this thing about divisions. If this is the spinal cord in cross-section, the spinal cord has two nerve roots that arise from it. Or rather, the spinal nerve has two roots that come from the spinal cord. There's a ventral root, which carry motor information, efferent function. So either going to muscles, like in this case, or glands. And then we have the dorsal root. The dorsal root carries sensory information. So the signals on this part enter the spinal cord, but the signals here leave the spinal cord. Related to the dorsal root is a ganglion. A ganglion is a collection of cell bodies of neurons, so it feels like a swelling. Because it is located near the dorsal root, we call the dorsal root ganglion. It's a sensory ganglion, cell bodies of sensory nerves. All in all, the dorsal root and the ventral root of spinal nerves join to form the spinal nerve. And so a spinal nerve is a mixed nerve having both motor and sensory functions. This spinal nerve divides into two, and those two are called the rami. The ramus means branch. The dorsal ramus and the ventral ramus. Both the dorsal ramus and the ventral ramus are still mixed with sensory and motor components. Dorsal ramus generally go to the back of the body. The structures innervated by the dorsal rami may not have migrated so much during embryonic development of a human being, and so they tend to be segmental. But the ventral ramus, the structures supplied by ventral ramus seem to have migrated significantly, and especially in the region of the limbs. It is for that reason, therefore, that the nerves from the ventral ramus form plexuses, but the nerves from the dorsal rami do not form plexuses. So the plexus that go to the lower limb is called the lumbosacral plexus, formed by both the lumbar plexus of nerves and the sacral plexus of nerves. The ventral rami are the one that form plexuses of nerves. The ventral rami that give you, or rather, let me put it this way. Usually the ventral rami will also have two divisions, the anterior division and the posterior division. From a functional point of view, the posterior division tends to supply extensor compartments, as well as the abductor compartments. And then the anterior division tend to supply the flexor compartments as well as the adductor compartments. Having said so, the femoral nerve is formed by the root value L2, 3, 4. So they understand that those are ventral rami of L2, L3, L4, but specifically the posterior divisions of the ventral rami of L2, L3, L4. So this image capturing for us the lumbar nerves, L1 to L5, because they're forming plexuses, these are already ventral rami. So the ventral ramus of L2, L3, L4 have posterior divisions and anterior divisions. So look here, we are focusing on the femoral nerve. So this is the femoral nerve coming from segments L2, 3, 4 of the lumbar nerves, posterior divisions. This other one is obturator coming from anterior divisions of the same segment. Now let's focus on the femoral nerve. What's the cause of the femoral nerve? Femoral nerve runs between the muscle iliacus and psoas major in that particular groove there. That's where it lies. And so as it enters the thigh, it will enter the thigh in that groove between iliacus and psoas major. Remember that femoral nerve is not a content of the femoral sheath. It is lateral to the femoral sheath. The femoral sheath only contains the femoral vessels, femoral branch of genitofemoral nerve, which is different from this nerve we're mentioning, and some lymph nodes, as we mentioned. So this is femoral nerve lateral to the femoral sheath. It enters the thigh just below the inguinal ligament there. Immediately it enters the thigh. The femoral nerve divides almost immediately into many branches. It ramifies within the femoral triangle. So the branches that the femoral nerve gives within the femoral triangle are many, but let's classify them. The muscular branches are branches given to the muscles of the anterior thigh. There are several muscular branches of the femoral nerve given at its ramification. Most of these nerves are not named though, but remember we'd mentioned one called nerve to vastus medialis, which is also a content of the adductor canal. Apart from muscular branches, the femoral nerve also gives us cutaneous branches, which go to the skin of the anteromedial thigh, as well as the skin of the middle side of the leg and that of the middle side of the foot. These ones are named. The ones which go to the skin of the anteromedial thigh are the anterior cutaneous branches of the femoral nerve, which we had mentioned earlier, the intermediate and the middle one. And then the one which go to the middle side of the leg and foot is the saphenous nerve, which is also considered the terminal branch of the femoral nerve. So those are cutaneous and muscular branches of the femoral nerve. Let's now finish with the obturator nerve. The origin of the obturator nerve is still the lumbar plexus with the root value L2, 3, 4, but now anterior division. Now I don't have to belabor in making you understand what's an anterior division, what's a posterior division. So this is the obturator nerve. It runs within the pelvic cavity. Immediately it is formed, and it's usually joined by the obturator artery as they run together. Both of them pass through the pelvic cavity and exit the pelvic cavity through the obturator canal. Now remember, the obturator canal is an opening in the obturator foramen on the upper part of the membrane. The obturator foramen is covered by the membrane, obturator membrane, and above it is the obturator canal for passage of the obturator neurovascular bundle. So the nerve exits the pelvic cavity through this space to enter the medial aspect of the thigh, as you can see it. Usually as it enters that way, it will have now divided into two divisions, the anterior division and the posterior division of the obturator nerve. So two divisions enter the medial aspect of the thigh. Let's talk about their branches. The posterior division goes to three major muscles: obturator externus, adductor magnus muscle, and adductor brevis muscle. But it has a cutaneous distribution, a sensory distribution to the knee joint as well. So in this image, we can see the two divisions of the obturator nerve. Okay, first we can see its origin there, the L234, forming the nerve, then the two divisions, posterior division going to obturator externus, adductor magnus, adductor brevis, and having a sensory distribution to the knee joints. This is the one that was found within the adductor canal as a content as well. You can see it passes through adductor hiatus, just like the superficial femoral vessels. The anterior division go to the rest of the muscles of the medial thigh, including again adductor brevis. This anterior division gives you a articular branch that goes to the knee joint, to the hip joint, and then it gives you a sensory distribution that goes to the skin or the medial aspect of the thigh. So now it is important that we understand something here. In terms of clinical relevance, usually because the obturator nerve supplies both the hip joint through anterior division and the knee joint through posterior division, sometimes pain that is being carried by the obturator nerve can be confused. Is it coming from the knee or is it coming from the hip? So sometimes there could be a pathology in the knee, but a patient complains of pain in the hip, or vice versa. That's what we call pain referral. So pain from the knee can be referred to the hip, or pain from the hip can be referred to the knee because of obturator nerve. Both joints are supplied by the same nerve. Great, so that's the story of the obturator nerve, and that summarizes the story of the topographic anatomy of the anteromedial thigh. We will stop there. Our next topographic anatomy class in this series will be topographic anatomy of the hip joint. You can look out for it. Thank you.